Our last speaker is Lucia Knight, who's a senior lecturer in the School of Public Health at UWC, and she's going to be speaking about a family-based VCT program in KwaZulu-Natal.
Thanks, Di. Good afternoon, everybody. So I guess I'm shifting slightly because I'm talking about research that we're doing at the moment, but I hope that it has resonance for this session in the fact that we're talking about families and we're talking about communities, and I'm hoping that it'll talk to that second thing around how we can build on existing strengths to optimize child health and communities. So I'm hoping that we'll be able to get there. So what I'm going to present to you about today is talk to you a little bit about an intervention that we've been designing at the moment together with colleagues at the Human Sciences Research Council based in Vulindlela, for those of you that know Vulindlela in KZN. So to start with, I'll give you some background to the issue that we are interested in exploring. I'll talk to you a little about why we think it's important that family-based counselling and testing is necessary, and then I'll give you a very brief overview of the development of the model, and then tell you a bit about what the model looks like, and then tell you a bit about what we're planning to do with it. So traditional facility-based counselling and testing doesn't access all at-risk adults and children, and there are many people that are missed, most particularly men, children who are at risk from vertical transmission, and adolescents. We know that these people don't necessarily get tested in facilities. So this highlights the need for targeted, age-appropriate counselling and testing. And what we know from South Africa and from a number of other studies that have happened in sub-Saharan Africa is that home-based counselling and testing delivered by lay counsellors to adults is effective, acceptable, and often reaches many first-time testers, so people who haven't tested for HIV before. But there are limited examples of models that test and link the whole family. Those traditional home-based counselling and testing models tend to be biomedical and focused on the individual. And we're trying to think about it a little more holistically. So why is the family important? Well, in terms of HIV, the family is important because it's often the context of HIV infection. Sexual relationships, pregnancy, birth, breastfeeding often happen within the context of a family. The family shares in and tends to bear most of the responsibility for the care and support of those who are infected or directly affected with HIV. And we know that stigma, discrimination, and social exclusion are experienced by individuals, by families, and individuals within families, and so families are important. So AIDS has significant and often adverse impacts, often intergenerational impacts on family structure, functioning, and well-being. So with the rollout and access to ART, the family is potentially a very important source of support for linkage to care and adherence to treatment, which is one of the reasons that we wanted to think about the family. So what does a family-based counselling and testing intervention offer us? What opportunities does it give us? Well, it gives us it has the potential to influence a number of important areas. So these are some of the things that we're interested in and we're trying to target as part of the intervention. So the first is disclosure of status within the family, amongst and between family members, and we hope and we know from some other research that this has the potential to reduce stigma and to improve support, care, and treatment adherence. It also has the potential to reduce mortality and morbidity. We can get people onto treatment, we can start thinking about treatment as prevention, and we can ensure that people get onto treatment early. It's that thing about first-time testers. And it also supports linkage to care, which we know is very important, especially for people in the community. It also has the potential to address structural factors that influence HIV transmission and infection within the community, within the family, and within the household. So it enables us to start to think about engaging some of the social processes that may produce or reinforce some important prevention behaviors. So the aim of designing the intervention, I've already talked a little bit around this, was to develop a family-based counselling and testing model that provides HIV testing counselling, linkage to care, and also supports family members with disclosure, fosters intergenerational discussion about HIV, increases support and health promotion amongst family members. So what did we do? So this was a long and involved process, and I'm going to talk about it very quickly, but if you want to know more, I'm very happy to share some more information. We went through a very intensive intervention development process guided by this model called 6 Squid. And it involved 3 main phases, although the 6 steps are kind of embedded in the 3 phases that I'll talk about. The first was a literature review around the home-based counselling testing models that already exist, and some of the literature around family-based models, both those dealing directly with HIV, but other models as well around families. And then we did quite extensive formative research, qualitative research in Vulindlela with a number of different stakeholders, including families, children, adults, parents, people who are involved in the community, to explore people's ideas around a family-based model of counselling and testing. And then part of phase 2 was to try and pull together the results of phase 1 to identify a theory of change and what we could identify as the potentially malleable and modifiable factors that we could address as part of the intervention. So in order to do that, we did a data review workshop, a stakeholder workshop, a conceptual workshop. And what we came up with after all of these intensive exercises was that we identified 3 key factors that we thought came out as very strongly within the family that we could try and address to try and hit our outcomes. And those were the fact that there were very hierarchical relationships between generations within the family, that there was an inability to discuss sex across the generation. HIV is largely about sex, and so sex is important to be able to talk about, and that there was generally poor communication skills across the generations. So what we also identified and talked a lot about was adolescents as a key population, because we felt like they were people that we could, within the household, that we could clearly talk to, and that an intervention to address parent-child communication has the potential to reduce high-risk behavior. So we wanted to try and focus on these 3 things and this specific group. So phase 3 was to design the model, and so this is what the model looks like. We took 2 intervention design workshops and intensive consultation to get it. But basically what we came up with was 3 configurations of family types, and the model is a lay counsellor-led facilitated testing, but also that we wanted to address education and change agents within the household. So we decided that those were important things to deal with. So in order to do that, we wanted to try and look at communication skills, fostering positive relationships between parents and adolescents through identifying and positively reinforcing good behaviors, and encouraging talk about sensitive topics, including HIV. So one of the key outcomes is that we're not just interested in testing, which is the main outcome of this intervention, but also general health promotion and general talking about health, talking about the clinic, talking about access to care, that we could address at the same time as talking about the really important thing around testing that we were interested in. So we talked about, we used and designed a set of activities. We have drawn on existing resources from other projects, but there's an intensive family tree activity, which is a whole family activity pulling together all the members of the family to talk about issues. And then there's also a Let's Test activity, which has been designed for children under the age of 12 to do with parents, and then children over the age of 12 to do with parents, but also to do on their own as a larger group. So we encouraged paired or group testing. They got counselling, and there was also PEMA given at CD4 counts at the time of testing, and we also developed a supportive disclosure session. So this is what it looks like. It looks complicated. There's a lot of sessions. It's very intensive. So there's 3 different types of families that we identified: young families with no adolescents, mixed families with both adolescents and younger children, and older families. And what it involves is depending on what type of household the household is or the family is, they would be slotted into each of those and go through the different sessions. I don't have time to talk about this in depth, but you can certainly have a look at what we're doing. This is all published in a paper, and I'll give you the reference at the end. So what are we doing at the moment? Well, we are currently piloting the model. So we're waiting for those results to come out. And what we want to do is try and explore the potential for longer-term feasibility, acceptability, and sustainability of this model. And at the moment, this is a research process, so it's not necessarily delivered by lay counsellors, but we'd like to start exploring that and think about how we can do that. And we'd also like to further explore the ability of a model like this, or a simpler and adapted model, to be able to leverage a community-level intervention to try and strengthen families and build on the capacity that we have within families for positive HIV, sexual and reproductive health, and general health outcomes in the community. So this is the reference for the paper, and thanks to my co-authors, I'm presenting on their behalf.